have Dr. Richard Rieselbach from UW-Madison School of Public Health. Dr. Rieselbach, just let me make note of a couple things, is nationally known for healthcare reform issues. He's a Professor Emeritus of Medicine at UW School of Public Health. He also served at the Robert Wood Johnson Policy as a policy fellow with Senator Edward Kennedy on the Senate Health Committee. Dr. Rieselbach has special interest in this issue and also working on helping train the next generation of physicians. Dr. Rieselbach is author of numerous articles on public health issues and also just co-authored an article that appeared in the July 14th issue of the Milwaukee Journal on what role should primary doctors play in our national health care reform. There was some copies of that that I had in the back table. So with that introduction, Dr. Rieselbach, thank you for coming all the way from Madison.
Well, it's great to see you all out here. Can you hear me okay? Okay, well, let me start out by saying that the Kaiser Foundation made this video narrated by Koki Roberts. And one reason they did that is that there's so many outlandish myths about the ACA floating around this country. And they've made this investment to try and convey the facts. And one of the handouts you picked up when you came in was Bill Keller's article from the New York Times about the 5 major myths about the ACA. And I urge you to read that because that's an excellent article. Now, what I'd like to do is very quickly run through some slides which kind of review what you've heard and kind of put things in context about what's going to happen each year. And let me emphasize that the full name of the ACA is the Patient Protection Affordable Care Act. And what I'm going to do after those slides, I'm going to go into much more detail about 2 aspects of the Act that you probably haven't heard much about. One of them relates to cost control and what the Act involves to control costs, and the other relates to education of physicians, because this is a big problem. And of course, this is kind of my bag in terms of educating doctors. I'm a kidney doctor, and so I'm a subspecialist, but I'm particularly interested in educating primary care doctors. And as you'll hear, we have a tremendous shortage of primary care doctors now, and that's one of our major problems. So if we could run through these slides very quickly, and I'll just kind of walk you through them. And the next slide, these are just the key provisions of the Act. And as you can see, I won't even read most of this to you. I mean, you can read these on your own. And in 2010, the Act has already had some major effect already. I think you probably have experienced some of these advantages already, some of you who are Medicare patients. Next slide, please. And also effective in 2010, you can see several other issues that have been implemented. One of the more important things is the constraints on insurance companies. Insurance companies in the past have been making like 30–35% profit on insurance premiums. And that's one of the things the Act does, is limit the profit that insurance companies make to 80%. And some of you who have private insurance will be getting checks back in the mail in the next couple of weeks because the insurance companies have been forced to refund the amount of their profits over 20% on their insurance policies. And this is a major problem, I think, as you're aware. The insurance companies are fairly supportive of the ACA because it was tilted in their favor, because it was politically impossible to pass anything in Congress that did not support the insurance companies to some degree. And that's why the public plan, which was a public alternative to in the exchanges, didn't make it. Joe Lieberman led the charge to oppose that, and because the insurance company lobby was just horrendously strong. So at least we have some control over the insurance companies now. Next slide, please. And then effective last year, the donut hole continues to be filled in. Those of you on Medicare have experienced the donut hole, I'm sure. And that is being filled in. And the next slide, please. And then the big change comes in 2014 when if you live in the U.S. legally, you cannot be turned down for health insurance for any reason, whether you can afford it or not. There's subsidy for people who cannot afford it, and for people who have an income less than 130% of poverty, they will be eligible for Medicaid in most states. Now, you've all read about Governor Walker wanting to block the Medicaid expansion in Wisconsin. My own feeling is this is a lot of hot air, because what happens is that the ACA will pay the entire cost. The federal government will pay the entire cost of expanding Medicaid for the first 3 years, and after that, federal government will pay 95%. So that what you see, what you hear from the governor of Texas, the governor of Florida, our governor, is a lot of political hot air in terms of governmental interference with health care. But as we'll talk about later, this expansion of Medicaid is extremely important, and I think most governors will have a very hard time opposing this because there's going to be so much pressure around the country for this to occur for reasons which I'll go into later. Okay, next slide, please. And then other aspects of this effective 2014, and this reviews pretty much of what you saw in the video. And again, let me urge you to get a copy of that video. It's very simple. If you just take that Milwaukee Journal op-ed from July 14th that we published, the link to that video is in that op-ed. And I urge you to get a hold of this video and share it with your friends, because you all can be very effective ambassadors to try and clear up the myths in this community about the ACA. I think that's the last slide, isn't it? Yeah. Okay, if we could have the lights, please. Now, as I said, I think we can catch the lights on. As I said, this is just kind of was a brief review of the major components. And now I'd like to emphasize, as I indicated, the two parts of the PPACA which a lot of people are not aware of. One of them relates to cost. Now, I think as you heard from Keith in terms of the state of our healthcare system, we spend $2.6 trillion per year on health care, and that's about 17% of our gross domestic product. And I should point out that this amount is going to be rapidly growing unless we do something, because the demographics of our society are most compelling in terms of the aging of our population. And as we have a greater and greater percentage of our population in the aged group, the cost of care is going to continue to increase. Now, as you heard from Keith, our results in terms of our healthcare system are nowhere near as good in terms of morbidity and mortality as several Western countries, particularly many European countries, Canada. We're not doing well. And why is it that our health system costs so much, on an average twice that in many other countries? And why is it that we're not getting good results? Well, in terms of cost, would you believe that we waste about $800 billion a year in healthcare expenditures? And that amounts to about 31% of that $2.6 trillion a year that we spend on healthcare. Now, why is this? Well, first of all, our system is characterized by fragmentation of care. The best example, it's an extreme example, but the best example of fragmentation of care is what we call the Miami, Florida syndrome. Retired people in Miami go to their cardiologist on Monday, their gastroenterologist on Tuesday, their hematologist on Wednesday, and their orthopedist on Thursday. And they all order separate tests, and none of them communicate with each other with electronic medical records. So that we have this enormous duplication and fragmentation of care. And if these people have a primary care doctor, it's very likely that their primary care doctor never even hears what's going on. So that this is extremely costly, and it goes on in many parts of the country. Miami is the extreme example. The people at Dartmouth have done a very interesting survey around the country showing that there's tremendous diversity of healthcare costs in Medicare. In some areas, Medicare is reasonably cost-effective, very cost-effective, whereas areas like Miami, it is very cost-ineffective because we really don't control what goes on in terms of fragmentation. Now, another reason is that doctors order too many tests. Are there any doctors in the audience, by the way? Well, you're going to be, I don't think you're going to be upset with me because most doctors in the audience or every place now pretty much agree that what we have to do. Because a group of medical groups, the cardiologists, the orthopods, all the subspecialists have all outlined now procedures that shouldn't be ordered and tests that shouldn't be ordered. And what goes on is amazing in terms of the money, the way we've been wasting money. For example, the test for prostate-specific antigen, which is a test that tells you whether you have early prostate cancer. It turns out now, the American College of Physicians, which I'm a very active member of, has been saying for years, questioning whether this is worthwhile to do this test. We now have very strong evidence that it's not. Because in people over 70, it's not worthwhile to do because this is a form of cancer that takes years and years to get people in trouble. And many, many people, when they're 85 or 90 and finally go on to pass away, have small little vestiges of prostate cancer. So it's a very common cancer that currently goes without causing harm to people. But when you do this test, this causes doctors to want to do biopsies, and often 3 and 4 biopsies at $4,000 a piece. And then if the biopsy is positive, then there is often prostatectomy that's done, often by various new techniques where you really have to have expertise to make these techniques worthwhile, otherwise patients get into big trouble. So there's substantial complications. So in addition to the enormous amount of money that's spent by doing PSAs on older people, we see a lot of procedures and tests which get people in trouble. Now, in addition to that, location of care. And this is a big one. And that is that many people cannot find a primary care doctor. And as sure as you all read, we have retail medical clinics springing up all over. And the retail clinics are springing up because people can't have access to their primary care doctor. 50% of people who go to these retail clinics have no primary care doctor. Now there are about 1,400 of these retail clinics at Walmart and Walgreens and CVS in the country so far, and others are going to be springing up very rapidly, particularly with healthcare reform coming in. Now, the problem is, if people don't go to their primary care doctor or these retail clinics, they go to the emergency department. A very significant percentage of visits to emergency rooms are not warranted. They could be handled beautifully as outpatients in a primary care doctor's office or at a community health center, which we'll talk about in a minute. And these visits, patients get charged an enormous amount of money for these visits, and many of these patients can't pay for these visits because they don't have insurance. So what does the hospital do? The hospital has to stay in the black, so they raise their rates to insurance companies in order to cover these visits, these unnecessary visits to the emergency department, which this happens all over the country, particularly in inner city areas. And so who pays for this? Well, those of us who have health insurance pay for this. In other words, we all pay for these visits to unnecessary visits to emergency departments in order for hospitals to stay in the black. And of course, this is one thing that the ACA is going to do. Number one, it's going to provide insurance for these people, and hopefully many of them will not go to emergency departments, but they'll go to primary care doctors, and we'll talk about that in just a minute. So that these are some of the major problems in terms of cost. Now, what is the solution? We've kind of touched on solutions so far, but one of the solutions I'd like to point out is something called IPAB, the Independent Payment Advisory Board. And this is part of the ACA, and this has drawn the ire of many of our friends in the Tea Party, because they feel this is unauthorized government involvement in healthcare. And I think there are some physicians groups that are a little worried about this. And what this does is this is a panel that would look at the cost of Medicare. And when Medicare exceeds a certain level that's set up as reasonable, then they would look at the reason for some of these excesses. And what they would be stressing is what we call evidence-based care. In other words, they would be carrying out and endorsing studies which allow doctors to know what the science is supporting what they do. And the best example that I can give you in terms of where the science really went astray is breast cancer. Several years ago, it turned out that there was a lot of excitement around the country in terms of doing bone marrow transplants on women who had advanced breast cancer that didn't respond to chemotherapy any longer. And there were centers that sprung up all over the country who were basically what we call frying the bone marrow, extensive X-ray treatment to the bone marrow, wiping out the cancer, wiping out the bone marrow, and doing bone marrow transplants. It turned out that there was no benefit to doing this. These poor ladies died a horrible death, and there was no positive effect of doing this. And this is an example of unbridled enthusiasm for promotion of techniques which do not have a scientific evidence in support of them. And what the IPAB will do is strongly push hard to sponsor studies before we pay for things like this to make sure they're warranted and that they are in the best interest of patients and not in the best interest of some entrepreneurial medical centers who have figured out a way of generating a lot of cash. Okay, now in terms of another solution is what we call the ACO, Accountable Care Organization. An Accountable Care Organization, I think you all ought to know what this is all about, because most of you within the next couple of years are going to be taking care of doctors who work in an ACO. An ACO is a group practice between the doctor and their group practice and the hospital. And the hospital and the group practice get together, and the money they save by not ordering tests that are not necessary, and by doing things according to evidence-based practice, the money they save, much of it comes back to them from the government. It's a way that the government, and that's what the ACA is talking about, in this part of the ACA that provides $1 billion a year for innovation. It's called the Center for Medicare and Medicaid Innovation, and it is sponsoring these ACOs, which are springing up all over the country now in the last few months. And the Marshfield Clinic, for example, has shown that these ACOs can save a lot of money, and they and their doctors have gotten some of it back in return. So that is something that our friends who are detractors of the ACA in Congress refer to this as a slush fund. refer to this $1 billion a year as a slush fund that doesn't do anything. And hopefully we can now show them what it's doing, and we already have some very tangible results in terms of what this does. Now, the other thing that is very important in terms of controlling cost relates to all of these new Medicaid patients. Right now, Medicaid accounts for maybe a large percentage, probably 25 to 30% of all payment of all care in this country. We're going to be, under the ACA, if the resistance from a few states doesn't materialize, the ACA will be funding another 16 million patients for Medicaid care. And even if Texas and Wisconsin and Florida don't go along with this, there'll still be 12 or 13 million patients who will be coming on board for Medicaid, with Medicaid support. Now, who's going to take care of these patients? Because right now, Medicaid patients, many of them can't find a primary care doctor, particularly in the inner city and in some rural areas. There's a real access problem for primary care doctors for the underserved. And it turns out that community health centers are extremely important in this regard. Now, the ACA provides $11 billion for expansion of community health centers over the next 5 years. Another $2.5 million was provided by the stimulus bill. Here in Milwaukee, 16th Street, Martin Luther King Community Health Center and others have already gotten some grants to expand. And right now, community health centers take care of 21 million people in this country. And it appears that if with the ACA, they will be taking care of up to 40 million people in this country. Now, what's the problem? Well, in Massachusetts, under Romney Care, if you will, when they got complete coverage and their Medicaid patients were covered by Romney Care, there was a wait of 3 to 4 months to even see a primary care doctor. They had tremendous problems with access to primary care doctors, and that's the model that we talk about, which is going to be going on in the rest of the country. And so we're convinced that primary care access is going to be a very significant problem, and that's where we come into this area of patient protection. For patients to be cared for well, to be really protected, we're convinced that they must have a primary care doctor who basically runs the team that takes care of patients. And the way we're going to make primary care doctors more efficient in the future is what we call the patient-centered medical home. This consists of physician assistants, nursing, advanced practice nurses, pharmacists, social workers, all the people now who are going to be working with doctors to make them more efficient and allow them to care for many more patients. Because we can't possibly produce enough doctors in the next 10 to 15 years to take care of all the patients we need for primary care docs. And community health centers are particularly good in working with the patient-centered medical home. They have received support from the ACA and the stimulus bill to help them do this and to help them develop electronic medical records. And community health centers are now extremely effective in caring for patients, and we're hoping that this is going to be a way that we can very effectively take care of 40 million or more people within the next 5 years in a very cost-effective manner, because community health centers get their drugs wholesale from drug companies. They have malpractice insurance from the government. They have about 15 different things that make them more cost-effective. Okay. And now, finally, what we're going to do is mention a little bit more about education, because much of what we've talked about relates to doctors of the future. Right now, doctors undergo what we call graduate medical education, residency training after medical school. It turns out that we haven't done a very good job of training our doctors for practice in the 21st century. And the Institute of Medicine has just started in a very important study, which will make recommendations to Congress, to recommend to Congress how we're going to change graduate medical education. And one of the things that we're very interested in is moving much more of graduate medical education into community health centers for primary care doctors, because we think that's where primary care doctors will learn to be cost effective, and in the meanwhile, they will greatly increase access to community health centers because their salary and that of their faculty are paid for by the government in terms of training for graduate medical education. So I think in conclusion, there are a lot of things going on right now, and much of this is all sponsored and paid for by the ACA. And so therefore, all of us in almost all the doctor professional associations are very strongly in support of the ACA, and I think when you talk to your doctor, particularly when you talk to your primary care doctor, you'll find that they understand the importance of the ACA. Thank you.
Thank you. I wanted to just see if anyone had one or two quick questions to ask to Dr. Rieselbach. You could entertain. Yes? You just have to speak up and stand up.
Would you please tell us the difference between the ACO and an HMO?
Okay, good question. An HMO has nothing to do with hospitals. In fact, HMOs have driven hospitals crazy over the last several years, and in terms of trying to cut reimbursement. An ACO is a partnership. It's a consortium between doctors in practice and the hospital so that they work together. So it used to be that hospitals would encourage doctors to order MRIs because they got to pay for the machine. And now in working together, they realize that if they can save money and demonstrate that they save money, that they're going to get a refund, that they're going to increase, the doctors and hospitals are going to get a rebate from the government in terms of money they save on Medicare. And eventually this will spread into Medicaid and probably into private insurance. So that's a very important point.
So who's the government? That's us, right? So we're paying for the rebates? So we're paying for the rebates because we are the government, correct?
That's right.
Okay.
That's right. However,
So it's out of
the
one
rebates
pocket and into the
come
other.
nowhere close to the cost. In other words, they're a small percentage of the money that's saved. So the net effect, the bottom line, is big money saved for all of us in terms of taxpayers.
Okay, one last question. Ross?
I thought your presentation was very good, and I would like to thank you for being with us this afternoon, this evening. But from what I have heard, the overuse of examinations and tests by physicians is motivated predominantly by fear of malpractice suits, which you're shaking your head and you agree. Does ACA have any provision for capping malpractice amounts?
Very good question. And the point is, it turns out that of the wasted money on medical care, of that $800 billion, only about 15% is due to malpractice fear on the part of physicians. But this is a significant factor. But another motivation is physicians just thinking that, you know, this is accepted care and they want to make sure that their colleagues think that they're good doctors and they're being thorough. But your point is very good. The reason the ACA does not have any major issues in terms of malpractice is the makeup of Congress right now. What, 80% of Congress are lawyers, 85%? And to get the ACA passed was a tremendous accomplishment on the part of Obama and the administration. And they had to make a lot of compromises. And one of the things they had to do was to keep the lawyers happy. Now, I am hopeful that, I mentioned community health centers have a strong malpractice limitation and support, and I'm hopeful that that spreads into the rest of I should say our state of Wisconsin doctors, our faculty. There's a cap on our malpractice. And malpractice caps are possible, and hopefully they will come on as we make progress in the next few years.
Okay, thank you very much. I appreciate those questions.